I am standing outside, and in case I fall short of the books, you can collect it from JP Publications.
Thanks for doing it. In angle closure glaucoma, recently much interest has been generated regarding the use of lens extraction, the utility of lens extraction in the management of angle closure glaucoma. Most of my talk would revolve around this topic. We all know that there are various predisposing factors for primary angle closure glaucoma: a decreased axial length, shallow anterior chamber, a narrow angle width, and a small radius of curvature of the cornea. Shallow anterior chamber, if we see, is caused if there is irido-lenticular apposition leading to relative pupillary block is well known, and this supports the pivotal role of the lens position and size in the active or the potential mechanism of angle closure. Now, the ability of lens extraction to control glaucoma and angle closure would depend on the extent of reversible component of angle dysfunction. So, if we have appositional angle closure which can open up following lens extraction, then that's something that might help in improving the outflow facility. It would also depend on the target pressure for the particular eye, and the angle function, as we know, can be compromised not just by peripheral anterior sanity but the iridotrabecular contact per se. We'll start off with acute angle closure attack management, and from the AGIS consensus statement in 2006, it was concluded that laser iridotomy should be performed as soon as feasible in the affected eye and then as soon as possible in the contralateral eye. Medical management was the recommended first step in treating acute angle closure. Primary cataract extraction, they said, may be a treatment option, but data supporting its use was limited. Lam et al. Have conducted a randomized controlled trial of early phacoemulsification versus doing a peripheral iridotomy in preventing intraocular pressure rise after acute attacks in primary angle closure. So they compared the efficacy of early phaco versus a iridotomy in preventing intraocular pressure rise in patients after acute attack. They had 31 eyes in each arm, and this was a prospective randomized controlled trial. Now, what were the results? They showed that the prevalence of intraocular pressure elevation at 18 months was 3.3% in the phaco group and 46% for the iridotomy group. The angle was significantly more open after phaco compared with LPI. There is a significant difference in the mean number of glaucoma medications that were required to maintain IOP less than 21. In the phaco group, it was 0.03, whereas it was much higher in the iridotomy group. So that is a huge case for lens extraction in acute angle closure. But then let's look at what's between the lines. Now, these cases were those cases of angle closure where they had been able to abort the attack by using topical and systemic anti-glaucoma medications. All these eyes had presence of cataract. So that's very important to note. All these patients received phaco or LPI within days after the abortion of the acute attack. As soon as the intraocular pressure could come down below 21 and when the inflammation had settled sufficiently for safe intervention. So it's only in this situation that what we have heard so far might hold good. So we cannot look at unaborted attacks and try and do phaco in those hot inflamed eyes. If you look at this table that they have given regarding the baseline data, the onset of self-reported symptoms to consultation was 2 to 3 days in the phaco group and the LPI group. And we know that in India, many times this can even stretch to months. Okay, so very often we see patients not reporting within 2 or 3 days, and they come, even they would have been treated elsewhere. By the time they land to it, maybe a week, 2 weeks, or even much later. The time needed to abort attack on an average was 11 hours in the phaco group and 9 hours in the LPI group. So the eyes have been easy to settle down. The time between the abortion of attack and the phaco was about 5 days in both groups. Now, another important thing that we need to look at in the study was what was the complications that they saw. In the phaco group, they had intraoperative corneal edema in 12 eyes, posterior capsule rupture in one eye, intraoperative bleeding from the iris root in one eye, postoperative fibrin AC reaction in 7 eyes, and visually significant PCO in 5 eyes. The LPI group had one closed iridotomy and small iridotomies as the complication. They also mentioned in their study that the phaco was performed by a single experienced surgeon, and these results may not be generalized to the less experienced. So the risk-benefit ratio of phaco in eyes with good visual acuity after abortion or in those eyes with no cataract is a subject of debate. So the study clearly says these are eyes with cataract, and though maybe we could extrapolate, but these are not eyes with clear lenses. And this may not be valid for other scenarios, especially unaborted acute attacks. I do think the complications are a little unacceptable. Early presentation in India may not always be the scenario. They have not mentioned as to how many of the eyes they could not settle with anti-glaucoma medications. Many times we see that the eye finally settles down only after you have done the LPI. Giving any amount of mannitol or any other topical systemic medication does not settle down the eye, and it's only a LPI that finally quietens. So I would prefer that. Why do we need to make a choice between iridotomy and lens extraction? We could do the iridotomy, allow the eye to settle down, and yes, if we still think that the pressures are going up, we can always do the cataract extraction a month later or so when the eye has well settled down. Acute intervention with lens extraction as primary treatment in APAC still remains less appealing than conventional methods. Now, while we are on the same topic, we'll also talk about peripheral iridoplasty, argon laser peripheral iridoplasty in acute attacks. Lam et al. Did a study and again compared iridoplasty versus systemic medical therapy in the treatment of acute primary angle closure, and they found this to be a safe and more effective alternate to conventional systemic medications in the management of acute PACG, which were not amenable to immediate LPI. And this was within the first 2 hours from the initiation of treatment. So only in those eyes where LPI was not possible, iridoplasty might help in being effective as an alternative to medications in breaking the attacks. If we look at iridoplasty for angle closure, which is non-acute, then this does not hold good. There was one RCT with 158 participants, and the result clearly said that there was no evidence for its role in the treatment of chronic angle closure. There was no superiority either for the intraocular pressure reduction or for the number of medications or for the need for surgery. They did note a significant reduction in PAS, the peripheral anterior synaptoplasty, but the authors acknowledged the limitations that the gonioscopy was done with the Goldman lens, not with the indentation lens. The outcome assessors were not marked, so we would not look at iridoplasty for the long-term management. Now, if you look at lens extraction itself in primary angle closure glaucoma, Friedman et al. Did a database of systematic reviews for this lens extraction in chronic angle closure glaucoma, and they did not find any randomized trials at that point. They found 2 non-randomized trials, but they said that both the studies had poor methodological quality. Comparing lens extraction with other treatment modalities, they in the studies, clear lens as well as cataract lenses had been included. Phaco and ECCA had been done, TRAP with and without antimetabolized. So the information did say that maybe there's a biological plausibility and the effect of treatment may be good, but there was no proof of effectiveness. There were no other comparisons made with other forms of treatment for PAC, chronic angle closure. Similarly, Teranga et al. In 2009 in Survey of Ophthalmology made a simple statement that there is no evidence from good quality randomized trials or non-randomized studies for the effectiveness of clear lens extraction for PACG. Dr. Ravi Thomas et al. In their article in 2011 have again reviewed the literature for the role of lens extraction in PACG. In fellow eyes, they say that iridotomy considerably definitely reduces the risk of acute angle closure in a fellow eye, though we know that it does not entirely eliminate the possibility of another attack. It is a minimally invasive step, and so it should be the first step for such eyes. and clear lens extraction for the fellow eye is definitely not justified. LPI was able to prevent acute attacks in all 80 fellow eyes in this study by Ang et al. So fellow eyes, we would look at doing a LPI. Now in PACS, we know that the risk of acute attack is 0.1% per year overall and 1% per year over 60 years of age. Now, even LPI is not standard treatment. We don't do LPI for all patients of PACS. Definitely cataract extraction may not be indicated for visual. Cataract extraction would only be indicated for visual reasons. Clear lens extraction is definitely not indicated for PACS per se. In primary angle closure, initially conventional laser peripheral iridotomy and anti-glaucoma medications are what we look at. However, if the angle does not open post LPI, if there is raised IOP despite LPI, if there are recurrent attacks, if there are persistent symptoms, if the pressure is uncontrolled with medications and argon laser iridoplasty, and if the sufficient area of the angle we see that can open on indentation, one could consider lens extraction. There is no data to support combining clear lens extraction with goniosyncytial. However, I do think that if there has been an acute attack and a recent onset of posterior synechiae, personally it does seem to work well if the synechiae are recent, the inflammation is controlled and one does a careful procedure. They do tend to help. However, I do not think that they have the same role if it is chronic angle closure. Seems reasonable to believe that if lens extraction would help, whether it is a clear lens or a cataractous lens, the angle architecture would improve and the benefit would apply whether we are removing a clear or a cataractous lens. But what we need to remember is that the risk-benefit ratio then just gets higher. We have two major RCTs from Tam et al. Where they have studied phacoemulsification versus a combined phaco trap in medically controlled and medically uncontrolled chronic angle closure glaucoma in the presence of cataract. One deficiency here is that the extent of appositional or synechial closure has not been clearly mentioned because, like I said, the benefit of lens extraction would depend to some extent on the presence of appositional closure. In both groups, they found that phaco alone, not doing glaucoma surgery but phaco alone, was comparable with the phaco trap. However, there was a greater need for use of postoperative glaucoma medications in the phaco-only group. Intraoperative complications were similar in both groups and these were basically related to the cataract surgery. But postoperative complications were higher in the combined surgery group and these were almost entirely related to the trap surgery. In the medically controlled group, combined phaco trap with mitomycin C gives a marginally more effective pressure control than phaco alone. This was resulted, however, in more postoperative complications. These were not very serious and they did not translate into any form of worse clinical outcomes in terms of vision or the visual fields. Now, what we would want to look at when we are deciding on what we want to do for a patient is to see whether this marginally better intraocular pressure control with combined surgery justifies the potential additional risk of complications and the additional surgery that might be required, say for a oblique or for a shallow AC, in handling these complications or to improve the filtration. Cataract extraction alone may be useful in cases of medically controlled PSEG, where there is some degree of appositional closure that can be opened. The addition of a trap may not be needed, provided a continued requirement for the use of glaucoma medication is acceptable to the patient. So the patient needs to understand that if his cataract alone is removed, there may be a need for the use of glaucoma medications. Chronic angle closure eyes with phaco alone perform a very small percentage, 2.9, eventually required a second stage trabeculectomy. In the medically uncontrolled, combined phaco trap definitely gave lower pressures than phaco alone at all time points. This was about 1.5 millimeters. Though this was not statistically significant, clinically we do think this might be significant. 4 eyes in the phaco alone group eventually required trabeculectomy. However, the trabeculectomy did not fare worse in any way. It had good results. more post-operative complications in the combined phacotrap, but again it was not reflected in the vision acuity or in the fields. Mean post-operative number of topical drugs on an average was much lower in the phacotrap group. In the medically uncontrolled group, addition of a trabeculectomy may provide a significant IOP reduction. Now, what happens if the same situation is there with the clear lens? Like I said, we could probably look at extrapolating the results, but understand that there is a higher risk to benefit ratio. In medically controlled glaucoma, if there is no cataract and the pressures are already controlled with medications, why are we even looking at surgery? So there is really no indication for surgery unless the patient is intolerant to medications, you want to decrease medication, and then if so, we could probably consider trabeculectomy alone. If lens extraction alone is planned, what we are concerned about is, will the intraocular pressure reduction be adequate? Possibility of IOP spike post-cataract surgery has to be kept in mind. And later, if we still think that trabeculectomy is required, we would need to wait for 6 months for the inflammation and the eye to settle down so that the tongue works well. So, in conclusion, there are no RCTs that actually support the use of clear lens extraction as a treatment for angle closure. A benefit from the procedure is biologically plausible. Extrapolation from existing randomized trials to a few specific situations may be possible. Any potential benefit has to be carefully weighed against the risks of intervention. We currently have a study by Azura et al. To look at the effectiveness of early lens extraction with intraocular lens implantation as treatment for BACT, what is known as the EAGLE study. It's a multicentric randomized trial. A single main analysis will be done at the end of the trial, which is at 3 years of follow-up. 400 participants with 200 in each group. The quality of life, vision, intraocular pressure, stability of the disease, safety of interventions, and economic implications are being looked into. The results should probably be out this year. In conclusion, earlier removal of cataract seems to be a reasonable option in primary angle closure disease. At present, there is no published data to guide the use of clear lens extraction for this condition. The results of the EAGLE study to address the practical question of clear lens extraction in primary angle closure disease is awaited. Thank you.
Thank you, Sati. What we could do is probably, since we are running short of time, we could cut down the talks a little and have the discussion in the end. If there's any specific, Professor Rajesh Kumar from Narayan Nethralaya, who will be talking to us on studies in ocular hypertension and open angle glaucoma.
Thanks, Pradeep. So I'm actually filling in for Dr. Gauri Murthy. She requested me to do this, and I think thank Vineet for allowing me to do this talk. So I think we all know that ocular hypertension is the most important modifiable risk factor for glaucoma today, and we all know that we call it ocular hypertension when the pressures are more than 20 millimeters of mercury on more than a couple of occasions. Fields are normal, there are normal optic nerve heads, and angles are open. Having said that, there is a bit of modification where we could typically consider ocular hypertension to a certain extent, although they are classified as AIOC, and even patients who have secondary cases of ocular hypertension from post-surgical could also be included in this, because at the end of the day, we are looking at the risk factor in total and not just what the final outcome is here. So all we do know that ocular hypertension may eventually evolve into open angle glaucoma over a period of time. How much time depends, at least is what is projected from multiple studies are 5 to 10 years. So approximately 5% of people over the age of 50 could have ocular hypertension, and if untreated, according to some of the studies like the EMGT and the OATS, they have reported that 1 in every 10 people with OATS will definitely develop damage over a 5-year period after diagnosis. So do we treat all patients with ocular hypertension? The implications are huge. There's a cost factor, there's a problem with quality of life. We all know that glaucoma patients are sort of labeled as having disease, and it is in many ways, including India and other countries, a social stigma to walk around medications. There are side effects of the medications. It's a lifelong treatment. There are issues with compliance. And at the end of the day, there are benefits about how effective this really is. So, we as doctors have the responsibility of providing patients with care based on evidence that is currently available and not what is anecdotal. So, if you look at a meta-analysis that was done recently, so a couple of large-scale RCTs, including the European Glaucoma Prevention Study, the ocular hypertension treatment study, the early manifest glaucoma trial, and a few smaller RCTs using multiple methodologies are available. And the old study, as we all know, was a large multi-center trial done out of the US, where they looked at people, about 1,600 people with ocular hypertension, and they took glaucoma medication versus observation and found that the treatment reduces the 5-year risk of developing glaucoma by half. Having said that, it did not completely negate or stop glaucoma from developing, even in those that were treated in all patients. So less than 10% of subjects in either group developed glaucoma over a 5-year period, which means that even if you didn't treat, many of them did not develop glaucoma. So that's the major question here. So then they looked at the number needed to treat, and they found that it was about 5.1 would be the estimated risk reduction. So if you look at the number needed to treat, which is about 20 by calculating the relative risk, you actually found that you have to actually treat 20 patients for 5 years to prevent one person from progressing to glaucoma. Now, when that is called glaucoma, it could be a structural change or a functional change. So you're looking at maybe one little nerve fiber defect or a hemorrhage, and that is the big question you have to answer. So the number needed to harm was about 2.1, which means that 1 in 48 patients would require cataract surgery due to long-term treatment to prevent glaucoma, which is not bad if you look from the cataract surgeon's point of view. Visual field loss, an outcome more likely to be associated with decreased quality of life. Then if you take that as the end point and not just structural change alone, then you're looking at the treating 40 plus patients over 5 years to prevent one person from developing or progressing to the next stage of glaucoma, or next stage is glaucoma. And blindness, almost improbable. So you're looking at treating 80 patients over 15 years to prevent one person from progressing. Cost effectiveness, and it would take almost $90,000 to prevent one person from progressing to POAG over a 5-year period. If you look at the cost burden on the patient, or in this case on the US government, if you look at it that way. So, should we not treat all ocular hypertensions? Those with definite risk factors, increasing age, thinner corneas, vertical compass ratios of more than 0.7, which is not really acceptable in our current practice as glaucoma specialists, because we all know that 0.7 is nothing but a number. We have to look at the neuroretinal rim. If there is a defect, that should be something that would have been added on and should have been at that point in time, which they couldn't modify obviously later. And central corneal thickness was added as a second, as a major endpoint or as a risk factor much later. It was more of a post-hoc analysis. Then pattern standard deviation and intraocular pressure were all considered added risk factors. I have explained this. So both ocular hypertension with increased IOP and inverse relationship with central corneal thickness. So they developed a few risk factors and risk calculators. I will skip these. So the other important risk factors they found that, especially from the early manifest glaucoma trial conducted in multi-center trial in Europe, that silver exfoliation was a major risk factor, and that obviously could not be studied in the US because that's not a very prominent or a prevalent manifestation there. POAG in the other eye and trauma are also added risk factors. So there are multiple studies on open-angle glaucoma. The early manifest glaucoma trial was a long follow-up trial of about 10 years and recruited a large number of patients, and entry criteria were mean deviation of -4 decibels and median IOP of about 20 millimeters, and randomized to initial treatment with a selective beta blocker and ALT, or left untreated until signs of progression appeared. So, and here they actually highlighted that every 1 millimeter of IOP reduction was associated with a risk reduction of 10 to 13%, which is you're getting a relative risk of 1, and that is to be thrown out of the window if you look at it, because a relative risk of 1 just says it's equivocal, but that is grossly highlighted by many of the pharmaceutical companies, and it still is, and we still follow that. The rate of progression in early managed glaucoma trial, they found that it's variable and difficult to predict even in those that are being treated. So most patients eventually progress to some extent, even if pressure is always normal. And that is the take-home message in many ways, because you can treat as much as you like. There are obviously other vascular factors and other extraneous factors that are causing the progression. And mean IOP fluctuation was not found to be a risk factor when the mean IOP was taken into account. Take-home messages from the EMGT were follow progression closely and reset target if required, and measure the IOP and test fields frequently, beginning at the beginning of diagnosis, and to sort of have a baseline and then to assess the rate of progression. Target pressures may have to be reset as you treat the patient, depending on whether he or she is not progressing or not. And it is important to identify and recognize pseudoexfoliation as a major risk factor. And this is more so even in a country like India, where pseudoexfoliation is reasonably prevalent. Now, what is the issue with how we adapt this? This is important. Do we extrapolate the results of the OATS and the EMGT to our population? What are the pitfalls? What are the benefits? What do we take home from these RCTs? So, developing world economy, low or middle levels of GNI per capita. In 1999, it was found that it was less than 10,000, or less even for that matter. And more than 80% of the world live in our part of the world, as we call it, as emerging economies of developing countries. And glaucoma is the second leading cause of global blindness and the most common cause of irreversible blindness. And India is set to be the capital of glaucoma by 2020, according to Quigley's article about glaucoma in 2020. Existing facilities and standards of care, as we all know, have major drawbacks and are not standardized as of now. Now, do we screen glaucoma with a prevalence of 2%? We don't think so. That would be a waste of resources. Case detection. Now, that is something that is being missed even in the regular clinics in our hospitals. So, the idea would be to do what we call opportunistic screening, which means a patient comes to you for pterygium. You make sure you look at the fundus. You try and do an intraocular pressure measurement. You try and do a gonioscopy. At least look at the fundus and look at the optic nerve. By looking at the optic nerve in the posterior pole, you're definitely picking up glaucoma, you're picking up diabetic retinopathy, or you're picking up a neuro-ophthalmology problem. So, opportunistic screening for the disease would be a much better approach than looking for glaucoma per se, because you're not going to find it that easily. And of course, there are competing costs. Would anybody or the government or any funding body fund that, or fund how to do sanitation and healthcare, and fund cancer research, or fund cheaper cardiology surgeries, cardiac surgeries? That's a question. So, like I mentioned earlier, what's a good number needed to treat? That depends. If you're going to prevent one death from rabies, then you give rabipur vaccines to 200, and 1 in 200 is a great number. But if you're going to prevent, like I mentioned earlier, one structural defect from developing, then 1 in 20 may not be a great number for a developing country or from a developing perspective. So there's something also known as population attributable risk. It is the percentage of risk in a population associated with the risk factor that may potentially be eliminated if the intervention is done. And that will then help us decide whether there is a public health issue or not. So a population attributable risk of 20% can be reasonably significant. 40% is great, and that's what the government agencies look at to, say, for example, interventions like provision of clear drinking water, sanitation, and immunization. The number needed to treat, or the par, from attributable risk from the old study extrapolated was about 8.5%. That's way too low for anyone to even look and notice, at least from an epidemiologist's perspective. The EMGT gives a much better result. It looks at about 20%, and that would then maybe be qualified as a health issue. I'm not going with the digits. I think Dr. Ratra is going to sort of talk about this later. So, in conclusion, treatment of ocular hypertension has an NNT of 20 over 5 years. Targeting high-risk cases can reduce this to a justifiable 6 or even less, which is great. Now, the NNT for the EM early manifest glaucoma trial was 5 to 6, and targeting again high-risk patients can further reduce that number to 3. The effective population attributable risk for ocular hypertension is about 8.5, suggesting that it's definitely not a health issue. And an effective power of 20% for early glaucoma is high enough for it to be considered a public health problem. And with that, it might just be enough to include POAG as a priority area for Vision 2020, which it is right now. Now, there are issues with opportunity costs, logistics and resources, and probably remain outside the realm of most public health budgets in emerging economies. And primary surgery may be a treatment of choice in confirmed cases, given the added health costs and the long-term problems with long-term treatment. And use of primary mitomycin may need further study with regard to, say, potential side effects if you look at the SIGIT study from a developing world perspective. Thank you.
Thanks a lot, Rajesh. That was a wonderful talk. We'll one of the drawings of glaucoma in India. So, sir will be talking to us on studies in normotension glaucoma.
Thank you, Vinny. I'd like to first. I would like to cover some of the aspects of normal tension glaucoma and what is the role of the randomized studies which you have and how we apply in clinical practice. First, normal tension glaucoma is a subset of primary open-angle glaucoma. The clinical presentation itself, studies have shown that when you look at the normal pressures versus high pressure glaucoma, the defects are slightly, probably, the demographic data is probably slightly different. When you look at this, while everything looks normal, only thing is they seem to have slightly thinner cornea and it's probably more female predominance. So demographically, it's probably slightly different. And the visual field data on the demographic shows there is probably more localized field effect than diffuse field effect. And as shown here, they can get more localized visual field effect here. And disc hemorrhage, localized non-fibrillary effect are shown, and localized field effects are shown, are typical of normal tension glaucoma. One of the studies which is probably we all have to know is the collaborative normal treatment study, where the purpose of the study was way back in 1980s when this study was conceptualized. There was clinical intuition was mixed. Some thought it was a condition was probably optic neuropathy and not a glaucoma, and probably IOP has nothing to do with this with this condition. So Stephen Drance and Dr. Anderson were the two lead researchers on the study, and what the study found was when the patients were randomized to treatment versus no treatment in normal tension glaucoma, while 28 eyes, that is 35% of the control progressed, only 12% of the patients treated progressed. So meaning thereby that treatment probably had a potential beneficial effect in patients with normal tension glaucoma. So when you look at the overall analysis, you can make out that probably even in patients untreated where did progress, probably the intraocular pressure had no role. So maybe it's unrelated to IOP in certain subset of patients. While 28% of the 28 and 35% of the untreated eyes worsened within 3 years based on the study criteria, 61 showed similar deterioration in the treated eyes. So 65% of the untreated eyes did not worsen. So within the first 3 years, however, most eventually showed a slow progression. But what is important is 12% of the patients who were treated progressed despite treatment. That is 30% reduction in intraocular pressure. Probably they slowed the progress, but still there was progression. The 30% lowering in the study was probably arbitrary, And filtration surgery achieved much higher reduction in intraocular pressure, but with the potential risk of cataract in those patients. So based on this study, they concluded that IOP was probably part of pathogenic process and IOP reduction is probably beneficial. But the potential IOP benefiting effect was probably masked by cataract in the treated group. So probably if you get a procedure where you get IOP reduction without getting cataract, probably it would be beneficial. Then the some analysis was done on looking at the natural course of normal tension glaucoma on patients who are untreated. And what they found was, while 1/3 of the patients showed a look-like progress in the 3 years, and half within 5 to 7 years. So what you have to do is, on the subjects followed for 3 years or more, 62 of the 92 did not show statistically change in the mean deviation. So meaning thereby that probably normal tension glaucoma is probably such a slow progressive disease. Maybe you can observe the patients for a few years before you jump into treatment for the patients. What they found was the risk factors were the patients were women and people who had a history of migraine, and patients with discam rate probably had a higher risk of progression. Probably race and family history is important because probably it's more common in the Japanese and Korean race. It's important to remember that this study, which was funded out of the AIOC, was funded by the Glaucoma Research Foundation. It cost 1.1 million, and it took 14 years to complete the study because NTG is such a slow progressive disease. In a slow progressive disease, it's difficult to see the progression unless you see the patient for a long time. So based on this, what are the implications of the normal tension glaucoma study? Probably the natural course is probably variable. The prediction on untreated course is probably not impossible, but you need to follow the patients. But we know there are some risk factors. The reason why this progression is important because based on the old study, the EMGT, the collaborative normal, the CGX study, what they found was even in the CGX study, you can see that progression, while mean reduction was good with the both surgery and medicine, both controlled the progression to such an extent that the progression was arrested. Supposing you can get target pressures, whether medicine or surgery, the later progression can be minimized. So if you look at this overall data of all the studies, the EMGT study and this thing, what you can see is that the amount of pressure reduction was variable with the OAT study, EMGT study, and its collaborative normal tension treatment. Whereas with the CG study, the individualized target pressures are achieved, and probably that's the reason why the low target pressure, the progression rate was probably less. So look at this risk factors of progression of last studies. You can make out that probably in the collaborative normal tension glaucoma studies, the discam rates and probably gender are probably risk factors. Of course, IOP probably is a risk factor here. So based on this, so what you can do is the EMGT study is one study which looked at all the subset of patients with glaucoma, be it high tension glaucoma, normal tension glaucoma, or pseudoexfoliation glaucoma. What they found was the patients with pseudoexfoliation glaucoma probably progress faster, whereas ocular patients with high tension glaucoma are somewhere in between, whereas normal tension glaucoma patients progress very slowly. Probably this study gives an idea how to look at patients who present you and treat probably normal tension glaucoma probably less aggressively, follow the patient for a few years before you decide to treat them more aggressively. So rate of progression, as I mentioned, in this is probably very slow with NTG compared to patients with high tension glaucoma or pseudoexfoliation glaucoma. And the median time to progression is probably also different, whereas the median time to progression is much faster with pseudoexfoliation glaucoma compared to somewhere in between high tension glaucoma, with the longest with normal tension glaucoma. So with normal tension glaucoma probably you need to have the patients for longer follow-up before you say that there is progression. What does progression mean for individual patient in looking at clinical practice? Suppose you have a patient who starts with 0 decibels and if he becomes minus 25 decibels, he's become legally blind. Suppose the rate of progression is like 1 decibel, it will mean that it will require 25 years for him to become blind. A rapid progression of 2.5 decibel would mean the person will become legally blind in 10 to 12 years. So rate of progression is something which you need to assess before you really go in and jump and treat more aggressively. So this is how you need to know that we all started 1.2 billion nerve fibers, and if the glaucoma, normal people lose about 0.4% per year, whereas if the person, the field detection occurs only after about 30% loss is there. So what you need to do is that the amount of the progression to visually debilitating visual defect as shown here depends on the rate of progression. What we know is that IOP lowering probably prevents progression. However, in many patients, progression can occur despite treatment. And even in low IOP, like in normal tension glaucoma, patients can progress. So can we treat all patients with glaucoma by simply lowering intraocular pressure? These are two patients who progress so rapidly, and within short time they become visually handicapped as shown here. So there may be probably IOP independent risk factors. Maybe we'll look at neuroprotection as a therapeutic paradigm, which is to prevent the death of neurons and probably prevent RGC death independent of intraocular pressure by looking at neuroprotection by various target mechanisms as shown here. One of the things which has been studies have shown that one of the neuroprotectors mentioned here is NMDA antagonist, that is memantine. Memantine is one drug which is already used in neurology in Alzheimer's disease, but unfortunately memantine in 2 randomized studies has been shown to be ineffective. Other neuroprotection is alpha-2 agonist has been shown to have receptors in the retina, and it has been shown clinically to be probably neuroprotective in animal eyes. While this memantine is ineffective in human beings, I would like to share something about the use of alpha-2 agonists subsequently. But other aspect also you should consider is that use of polyphenol antioxidants like ginkgo biloba has been adopted as neuroprotective agents. And effect of ginkgo biloba extract in patients with pre-existing visual field defect in normal tension glaucoma has been shown to be beneficial, but this is needs to be confirmed in further studies. There are some more studies which have been published which show that ginkgo biloba is probably an adjuvant in the therapy of normal patients with normal and high tension glaucoma. So it's important to remember that other risk factors in patients with normal tension glaucoma is a condition called obstructive sleep apnea, which is a condition which is associated with obesity, with airway abnormalities, and these patients also tend to have carotid plaques and coagulation abnormalities. Anecdotal reports have shown that treatment of obstructive sleep apnea slows down the progression of glaucoma. So maybe you may have patients who present with rapid progression. If you put them into sleep lab and they may have obstructive sleep apnea, treatment of obstructive sleep apnea may be one of the therapeutic methods in patients with normal tension glaucoma. So when you look at the protection and the weight of evidence, various studies have shown calcium channel blockers, alpha agonists and carbonic inhibitors. Very few studies have reached the stage of clinical evaluation. One study is the low pressure glaucoma treatment study, which is a randomized double-blind study looking at timolol versus alpha-2 agonist, brimonidine, to protect the visual field. The primary endpoint was to look at the visual fields in patients in the both groups. What they found was the patients who had brimonidine as a therapeutic method in normal tension glaucoma had a slower progression of visual field compared to timolol. So it's important to remember the 4-year visual field progression of timolol was higher compared to brimonidine. So this is something which may be kept in mind, because the low pressure glaucoma patients treated with brimonidine who did not develop had a less likely to have progression of visual field effect compared to timolol. The conclusion is probably, given the similar IOP lowering effect, there is probably IOP, non-IOP related mechanism favoring brimonidine in patients. They looked at the risk factors for progression in the low pressure glaucoma treatment study. And what they found was, while systolic and diastolic blood pressure and baseline follow-up risk factor, they also found a diagonal curve as a risk factor. And looking at the multivariate analysis, you can see that patients who are antihypertensives were also at a risk factor. Patients who had brimonidine had a lower risk compared to timolol. So probably based on this, the patients using systemic antihypertensives, older age, low mean ocular pressure probably are a higher risk of progression. So it's important to remember that Logis study demonstrate that there is probably significant reduction in the visual progression with brimonidine compared to timolol. So based on this, based on the proof of concept, based on the experimental edition, initial studies in non-arthritic ischemic optic neuropathy, Leber's hereditary optic neuropathy, and as well as the Logis study, we know that probably there is some role for brimonidine as a neuroprotector. So when you look at treatment options based on what we have learned from the studies, probably one is you lower the intraocular pressure depending on the patient's state of damage, keeping whether it's mild, moderate or advanced, and make sure that you have good control of intraocular pressure in advanced patients with pressures of lower than 16 millimeters of mercury. And treatment should be individualized for each patient with normal vision glaucoma. And also consider patients with risk factors as treat them more aggressively. And one thing is the use of calcium channel blockers, which is being touted as a treatment for therapy, it should be taken with a pinch of salt, because epidemiologic studies have shown that while the patients who are treated with calcium channel blockers had an increased risk of open angle glaucoma compared to patients who are on systemic beta blockers. So oral calcium channel blockers to treat normal vision glaucoma is still a question mark, because epidemiologic studies have shown probably that increase the risk, because increased risk of because reduction of the blood pressure without reducing the intraocular pressure probably risk the glaucoma more. Whereas with beta blockers, both the intraocular pressure and the blood pressure are reduced. Probably epidemiologically, probably the risk of progression to glaucoma is less. Is there more to glaucoma treatment than lowering the intraocular pressure? We have to consider the patient as a whole, consider the patient's systemic condition, consider the blood pressure, consider other factors, and also consider the patient's systemic condition, including obstructive sleep apnea. Consider neuroprotection as probably as one of the adjuncts, but still we need further basic clinical studies to suggest whether we need to change the clinical paradigm. But probably we are waiting for some exciting times ahead, because we get some neuroprotector, we can treat the patient independently of intraocular pressure, and probably treatment of normal vision glaucoma would be more rational. Thank you for your attention.
To talk to us about the epidemiological studies in glaucoma.
An ideal situation where you just have the faculty to talk to. So I'm going to talk to you on epidemiological studies in glaucoma, bench to bedside, as Vineet named it, or as I may call it, creating a clinical translational enterprise. Comprehensive eye study, the Chennai glaucoma study, and the study that we did in Nagpur, the Central India Eye and Medical Study. So I'm going to take you, give you some data about the prevalence of glaucoma from all the studies, but take you through the Central India Eye and Medical Study, because I'm best able to tell you how the findings of this study help to translate into bedside clinical care. And I'm going to cut short on some slides so that I'm able to run through the, just emphasizing on the important slides actually. So basically we studied 4,711 subjects with a mean age of about 49 years from a rural part of central India, which was about 40 kilometers out of Nagpur. And we had a very detailed questionnaire that included the social demographic questionnaire, and because we wanted to especially find out what was the influence of other things, other habits of patients, and the dietary habits, the smoking habits, alcohol, etc. And we also did a clinical eye examination, which was reasonably detailed and included the normal routine examination, including disc assessment, HRT, FDT, and macular photography. And glaucoma was defined by glaucomatous appearance of the optic disc, because we know that that's how we recognize glaucoma, and there are sufficient studies to indicate that the sensitivity and specificity of just looking at the optic disc to diagnose glaucoma is very high. And the optic nerve head was glaucomatous based on non-conformity to the Isn't rule, comparative thinning of the superior or inferior rim to the temporal rim, or an abnormally large cup in a small disc in association with the appearance of the retinal nerve fiber layer. And this is what we thought was important in helping us diagnose glaucoma. So glaucoma was detected in 193 eyes, that's 2.18%, and it was unilateral in 51 patients, and it was bilateral in 71 actually. So in the open angle group, there were 108 subjects and 172 eyes, and the primary angle closure group, there were 14 subjects and 21 eyes. And so, surprisingly, the ratio of open angle glaucoma to angle closure glaucoma for subjects was 7.7:1. This is just the reverse of what the Valori study demonstrated, and maybe there is a lesson in this. The prevalence increased significantly with age, which is expected, and for the study population of 40 years and more, the prevalence of all glaucoma was about 3.45%, and it increased so that in the study population of 60 plus years, it was about 7.50%, and the implications of this is that if this were a hall full of eye specialists and they were 60 years and above, then at the least 7.5%, that is 7 or 8 people out of 100 would have definitive glaucoma, and there would be many other glaucoma suspects and many other patients who would have maybe primary angle closure suspect or primary angle closure. So that's the implication of this actually, and that is truly frightening for what it's telling us. When we did the multivariate analysis correlating the presence of glaucoma with other parameters, then what is important is lower body mass index came out as being somewhat significant. A lower level of hemoglobin was also significant, and of course higher intraocular pressure, disc hemorrhage, but higher mean blood pressure was also significant, and in addition, the presence of myopic retinopathy, longer axial length, lower level of education. So it's telling us that there is this matrix of parameters that, when they come together, perhaps the risk will increase, and that taken alone also, they may have something to do with the development of glaucoma. And I think these are things that can be translated into clinical care actually. What was really surprising was that out of the 138 eyes with isgioglaucoma, that is when we used isgio criteria, and all of you either know about it or you can just take a look at what the criteria were, only 26 or just about 20% were considered to be glaucomatous with ophthalmoscopy. And that is a tremendous difference actually. And of the 193 eyes with ophthalmoscopic glaucoma, only about 15% eyes fulfilled the isgio criteria. And therefore, when we go back, we need to figure out whether the isgio criteria are suitable for global translation into our clinics, or whether that is an extremely simplistic way of saying that if you have, so much percentile, and you fall beyond that, then we are going to say that you have glaucoma, and perhaps we need to come out of that era now, and we have enough evidence to say that maybe the way that we can, even just on clinical photographs, take a look at the optic disc, may be much more important than just going and using the isgio criteria actually. And these are the prevalence patterns that in the Central India Eye and Medical Study, over the age of 40, we had a prevalence of all glaucoma of 3.45%. In the Chennai glaucoma study, in the urban population, we had 3.51 for POAG and 0.88% for PACG. And the Chennai glaucoma study rural, we had 1.62% for POAG and 0.87%. And of course, these prevalence figures that you should have 3.51% for the urban study, and you should have only 1.62% for the rural study that makes for extremely interesting reading. But of course, the most important thing was that the Chennai glaucoma study relied on ISGEO criteria to diagnose glaucoma, whereas we relied on ophthalmoscopic criteria. But nevertheless, the point is the difference between rural and urban prevalence, and that is something that we need to keep in mind actually. The urban comprehensive eye study was about 2.6% for all glaucoma included. The Andhra Pradesh eye disease study was about 2.56%, and angle closure there was about 1.08%, and the Vellore eye survey for those over 30 years and above was 0.41% actually. So there is a lot of variation, and I think it's got a lot to do with our own clinical expertise and how we diagnose glaucoma. But there are some interesting things that send us a message regarding the prevalence of glaucoma. And the ratio of open angle glaucoma to angle closure glaucoma was 7.7:1 in our study. In the Chennai glaucoma studies was 4:1. Urban comprehensive study it was 3.4:1. In the Beijing eye study it was 2.6:1. But in the Singapore Malay eye study it was 25:1 actually. And again, this makes for very interesting reading, that you might have thought that because you're a little bit east of India, then perhaps the ratio of open angle glaucoma would be much less to the ratio of to the prevalence of angle closure glaucoma. But that was not the case, and again I think that perhaps there may be a greater need to validate what we consider as primary angle closure glaucoma to have an across-the-board uniformity, and that would certainly be helpful. But of course, what is really important to understand is that primary open angle glaucoma is more common than primary angle closure glaucoma. So in conclusion, glaucoma prevalence in rural central India was determined, and glaucoma was associated, as I mentioned, with older age, lower body mass index, lower blood concentration of hemoglobin, high intraocular pressure, optic disc hemorrhage, and higher prevalence of myopic retinopathy and longer axial length. These were important parameters. How much time? I want to finish this in 10 minutes, and how much time have I used up actually? No, just okay. I'll just give you 3 examples of what are the clinical implications, or how do we translate this. One of the first most important examples that came out was that the optic disc size was determined for the first time in India at 2.25 with the HRT actually, and the range was 1.12 to 4.61, and of course we also came to know that the size of the optic disc in the community may be influenced by axial length, but this is completely another story, and we will recognize that the appearance of the optic disc is related only in a very different way with the axial length size actually. And the clinical importance of the optic disc size is something that all of you know actually, and this is the histogram of optic disc size from Central India Eye and Medical Study. The second important clinical translation parameter was that the mean intraocular pressure was found to be 13.6 millimeters of mercury, so that we needn't have to rely on something that was done way back in Wales, in Britain, or in the Baltimore Eye Study, and now we have a mean intraocular pressure reading actually. So that was an important parameter. And then this third parameter was that there was a determination of relationship of intraocular pressure with the blood pressure, suggesting that the blood pressure may influence the intraocular pressure. And of course now it's not enough to just correlate the intraocular pressure with the blood pressure, because there is an issue of translaminar cribrosa pressure that has come in, and I think all 3 of them have some sort of role to play in glaucomatous nerve damage. And the fourth clinical translational parameter related to glaucoma was that we found the central corneal thickness to be about 514 microns, and I think that's very important. And as we know, the Chennai glaucoma study readings were also about the same, and this is of course important because even though in a mild variation going up or down, it may not influence the intraocular pressure measurement, but of course when the CCT is very high or or much lower than the mean CCT, then we know that it does have an influence on the intraocular pressure measurement actually. So it demonstrates that clinical findings may have an impact on the assessment, diagnosis, treatment, and of course on the manpower planning, education, training, and resource allocation actually. And that's how we thought that there was a clinical translational value to all these population-based studies that have been mentioned in this study. Thank you all very much.
Thank you very much. Sorry for the small audience, but we'll all be talking about ourselves. I had nothing to do with it. So what I would be basically talking about is a initial glaucoma treatment study, a comparison between laser and surgery, that was the advanced glaucoma intervention study, and also the tube versus trabeculectomy study. Now the CIGTS was a newly diagnosed open-angle glaucoma. That was at visual field loss and the quality of life, and the secondary outcome was visual acuity, IOP, and cataract formation. So we were to look at the visual field mean deviation by time. We see that there wasn't much difference between either the medical or surgical group, but significantly over here we noticed that at around the 8 years, there was a 3 decibel decrease in the mean deviation of the visual fields. About the fear of blindness, the second question which they asked, they found that the initial treatment assessment, either medical or surgical, was not associated with fear of blindness. The most significant correlate over time in fear of blindness was the perceived impact on an individual's ability to perform a visual task. They also looked at medical versus surgical and the quality of life associated with it. They found that the quality of life was better with medical treatment, whether they looked at the symptoms with health problems, the symptomatic visual functional problems, or the local eye problems. When we looked at the IOP mean across the 2 treatment groups, the surgical group had a 48% decrease in intraocular pressure as compared to 35% in the medical group. This was statistically significant both from 2 to 9 years. The probability of cataract extraction was also higher, around 17% in the surgical group as compared to a 6% in the medical group. The surgical group also had more loss of visual acuity, even with adjustments for cataract-induced loss. About the trabeculectomy complications, other than cataract, there were bleb-related complications, which were the bleb revision in around 15%, and bleb-related complications like bleb leak, blebitis, and hypotony in around 10%. Endophthalmitis was seen in around 1%. So to summarize the CIGTS study, we did have an initial decreased loss of visual field, initial decreased vision, lower IOP, more cataract, and more ocular side effects with surgeries. There was an AGS survey which asked specific questions to all the glaucoma specialists, and from the responses they got, there were 3 questions which were asked. 1, are you more likely to perform surgery as an initial treatment for patients with moderate to severe glaucoma? Nearly 55.4% said no. They wouldn't perform surgery as the initial treatment. Are you more likely to counsel patients about the risk of cataract after trabeculectomy? Nearly 53% said yes, they would. And nearly 53% also said that their clinical practice has been significantly impacted by the CIGTS study. So what are our clinical implications? The implications are, we do not need to alter our current medical practice. We need to use the target intraocular pressure approach, where the visual field progression in both the groups was similar. Surgical treatment did cause more intraocular pressure drop. Advanced disease may benefit from early surgery. Exceptions are diabetics and African Americans. Fear of blindness is common, and when you newly diagnose a patient, you are supposed to reassure and tell him. Then we move on to the next, that was laser versus surgery. This was the advanced glaucoma intervention study, which compared argon laser trabeculoplasty with trabeculectomy. They were randomized into 2 groups. The ATT, where argon laser trabeculoplasty was done first, followed by trabeculectomy. If that failed, and the TAT group where trabeculectomy was followed by ALT if trabeculectomy failed. The outcome measures were again visual acuity and visual fields, and the secondary were IOP, complications, time of treatment failure, and adjunctive medications. They also compared the outcomes based on race. So when we look at the 10-year outcomes, and if you look at the whole group of patients, you would see that the average percentage of eyes with decrease of visual fields in the first 5 years was lower than the ATT group, but as it went beyond 5 years, the TAT group had lower field progression. Whereas if you look at the decreased visual acuity, the ATT always had lesser visual acuity loss as compared to the TAT group. In black patients, it was nearly the same, whereas in white patients, when we looked at the visual fields, there was a statistical significant lesser progression of visual field at 10 years in the TAT group. The visual acuity in the ATT group was always better than that in the TAT group, and in black patients it was visually significant through all the 10 years, whereas in the white patients it was significant only in the first year. If we look at the intraocular pressure change, the TAT group had lower IOP, but the difference in each of them was not statistically significant. The probability of cataract extraction was also higher in the TAT group as compared to the ALT group. As to what were the risks of cataract related to these complications, inflammation was the only one which showed statistical significance. If you had higher inflammation, your incidence of cataract was higher in the TAT group. And if we looked at IOP with visual field loss, they were divided into 2 groups. Those with intraocular pressure less than 18, they had no progression as compared to groups who had intraocular pressures always 50 to 75% or less than 75% of the times less than 18 millimeters of mercury. So what do we learn from the AGIS study? We learn that the relationship between low intraocular pressure and visual field loss remains an important finding. Lower IOP causes lower progression. In advanced glaucoma, lowering IOP to low teens means most will not progress. IOP fluctuation can have an important damaging effect, and cataract surgery is a side effect of glaucoma surgery. Risk factors, younger age and higher pre-intervention IOP, these increase the failure rate of both ALT and trabeculectomy. Trab failure is associated with diabetes mellitus and post-op complications, which are elevated IOP and marked inflammation. Cause of sustained decrease of visual fields in the ATT group was a male person and a worse baseline acuity, and in the TAT group it was diabetes at baseline. So we again go to the American Glaucoma Society survey. 3 questions were asked. Will you consider patient race initially in the treatment plan? Nearly 48.7% said yes, they would. Would you give greater consideration to diurnal variation after reading the AGIS study? Nearly 66% said yes, they would, and 70% said that their clinical practice has been significantly impacted by the AGIS. So in conclusion, yes, the cataract formation, the 5-year probability is increased to 78%, and with a trabeculectomy after the first trabeculectomy, and if you had a second trabeculectomy, the risk is increased 3-fold. Initial trabeculectomy retarded progression more effectively in Caucasians than Afro-Americans. Long-term visual function outcomes are better for the ATT sequence in black patients and better for the TAT sequence in white patients. Some patients progress despite low IOP, and some retain high IOPs despite multiple interventions. We then move on to the tube versus the trab. This was a multicentric randomized clinical trial to compare a tube, that's the 350 millimeter square barbell, to trabeculectomy with mitomycin C in eyes which have had previous cataract and or failed glaucoma surgery. The main outcome measures were the IOP, visual acuity, visual field, and surgical complications, and treatment failures were also looked into. The intraocular pressure in the first year was lower in the trabeculectomy group. However, the tube shunt was but through the 5 years they even out. Tube shunts were associated with more glaucoma medications than trab with mitomycin C during the first 2 years. This equalized with longer follow-ups, and trab with mitomycin had a higher failure rate as compared with the tube shunt surgeries. The probability of failure as seen here is more with the trab group. They also had higher reoperation rates. The vision loss was similar in both groups. Early post-operative complications were more with trab, but late post-operative and serious complications were similar in both groups. If we look at the failures of trabeculectomy with the TBT study, we'll see that the rate of failure was 10% every year. But at 5 years, the trabeculectomy had close to a 50% failure rate as compared to a 30% failure rate as seen in the TBT study. So the tube had a higher success rate than trab at 5 years, and the mean IOP number of glaucoma medications was similar at 5 years. So does that mean the tube is superior to trab? Well, no. TBT does not demonstrate clear superiority of any one glaucoma operation over another. Cost analysis cumulative expense is greater with the tube shunt. There is no significant difference between the two surgical procedures were observed in IOP at 3 months, medications used after 2 years, vision loss, rates of late post-operative complications, and serious complications. In the AGS survey, they asked them 3 questions. Are you more likely to perform a tube shunt instead of repeat trab with mitomycin C in eyes with previously failed trabs? 58% said yes. Are you more likely to perform tube shunts instead of repeat trab with mitomycin C in eyes with prior cataract surgery? 50% said no, they'd like to do a trab with mitomycin first. And nearly 60% said that their clinical practice has been significantly impacted by the AGS survey. So, well, it's difficult to translate clinical results of randomized controlled trials into clinical practice. You need to individualize. It's also look at the surgeon's preference. TBT just does support its use beyond just the refractory glaucomas. The primary tube versus trab study is a new RCT which is used to answer whether we should use it as an initial surgical procedure. They are looking at IOP as the primary outcome, and complication rates, visual acuity, visual field, reoperation and supplement medical therapy as the secondary outcomes. It's due for completion in 2016. So we do know that evidence-based medicine does give us the best evidence to how we should put this into clinical practice. But I'd like to quote this from the D. Modis's article in the Journal of Glaucoma, that a large gap nevertheless remains between the questions we ask and the applicability of information provided by the RCTs to daily practice. Lessons learned from major RCTs should be analyzed cautiously from the clinician's perspective. Collaborative, multicentric, practical clinical trials should help define the extent to which the findings of rigorous selected populations can be extrapolated to diverse clinical practice populations and to help answer new questions that may arise in medical practice. And thank you for attending the session, and thank you for your listening. I think they didn't say it. So even the current opinion said not much there. Most people you talk to also, actually, do you use?
Excuse me.
At all.
No.
Excuse me. Actually, in Bascom Palmer Institute, I have not done it, but I have seen a lot of expresses being done by Dr. Francisco Fuentes. Basically, Francisco Fuentes, he was a person behind express. So I have seen follow-ups of express also. So practically, I don't have an experience like without putting it, but I have seen follow-ups like patients, without seeing them, you can say that he will be 10 or 12. So I hope it would be 10 or 12. That's how he was quite impressed. But except him, other attendees like Dr. Ron and nobody was having that kind of practice with express. Only Dr. Francisco Fuentes, and unfortunately he died just last year.
And see, that's, I don't, like you said, I don't know how. The trick is, of course, is to, once you stick in the express, once you inject it in, you're very careful that it's not touching the iris at all. If it's, no matter how well you position it sometimes, unless you've done enough of it, I guess, it might tip a little down. So the one that tips a little down, I just went in with a vitrectomy probe from the other side and made a PI inferiority. That's the only way to do a PI.
I think it has another port being opened.
Yeah.
It's like blocking. It doesn't block while one blocking because it has another port functioning still once if one is blocked.
The size of the ostium has nothing to do with how much your intraocular pressure falls. What the tube shunt is doing is just making a consistent size. Nothing more than that.
One thing is, and he said he prefers it combined because if you do combined, the visual patients are visual anatomy the first few days because the trial, whereas the visual recovery is faster with express with the phaco.
Okay.
Yeah, exactly. Paul Palmer was there. Actually, Paul Palmer, Don Prudence, everybody hates it except Dr. Francisco Fenton. Yeah, that's
And
only
said that's much cheaper, we have much more promise with that.
See,
that is RD implant basically.
so this whole tube versus strap study came up because they get very good billing, reimbursement. They can bill the whole thing back to the insurance companies. So everything is industry driven and money driven.
And even in US, the practice is entirely like 60